Welcome to The Explainer. Today, we're exploring one of the absolute most critical anatomical maps in the entire human body. You see, to truly understand breast carcinoma, how it behaves, how it spreads, and most importantly, how we treat it, we really have to understand the breast's complex internal plumbing first. So we're going to map out the lymphatic architecture of the breast. It's this fascinating, intricate network that actually plays a dual role. On one hand, it's totally essential for normal fluid balance and immune defense. But unfortunately, it also acts as the primary transit system for cancer cells. Let's dive into it.
85%. Let that number sink in for a second. That is the massive volume of lymph fluid from the breast that drains directly into the axillary nodes, basically the armpit. This single statistic immediately establishes just how high stakes the axilla really is. I mean, sure, the breast has a few other minor drainage routes like the internal mammary nodes near the sternum, but the vast majority of the fluid relies entirely on this one axillary pathway. Because of this incredibly concentrated drainage, if a pathology like carcinoma develops, those axillary nodes become the absolute front line of defense, and sadly, the very first site of metastatic spread.
So here's our roadmap for today. We'll start by tracing 1. The lymphatic highway. Then we'll break down 2. The anatomy of the axilla. From there, we'll track 3. The path of metastasis. And finally, look at 4. Staging and surgical interventions.
All right, Act 1. Let's start by mapping the initial terrain of the lymphatic highway. Think of this flow like a highly efficient one-way highway network. The journey actually begins deep inside the breast, right near the milk-producing lactiferous ducts and the interlobular connective tissue. From there, the fluid communicates with the subareolar plexus. That's a really dense network of vessels located just beneath the areola. Once the fluid gathers up there, it heads outward. These outgoing or efferent lymph vessels pass right around the lateral edge of the pectoralis major muscle, pierce the surrounding fascia, and make a beeline straight for the axilla. It's a highly organized system designed to constantly sweep fluid away from the breast tissue.
Moving right along to Part 2, Anatomy of the Axilla. Let's look at the specific toll booths on this highway.
Now, what's really interesting about the axilla is that when surgeons navigate the space, they aren't just looking at some random, disorganized collection of nodes. Notice that small, triangular muscle lying deep beneath the chest? That's the pectoralis minor. This muscle acts as the ultimate anatomical anchor. Lying safely beneath the much larger pectoralis major, surgeons use the pectoralis minor as their primary reference point to divide the entire axillary region into 3 distinct, highly clinically relevant levels.
So, using that specific muscle as our anchor, the geography becomes crystal clear. Level I nodes sit on the outer edge, they're lateral to and just below the lower border of the muscle. This group includes the axillary vein, external mammary, and scapular groups. Level 2, well, that hides deep, directly behind the pectoralis minor, and it includes the central group and Rotter's nodes. Finally, Level 3 sits medial and above the upper border. These are your apical or subclavicular nodes. This simple 3-level grid gives doctors a universal coordinate system to describe exactly where they're operating or exactly where cancer has spread. Which brings us to a much more urgent part of our journey. Part 3. The path of metastasis.
We have to introduce the dangerous cellular hitchhikers on this highway. Carcinoma cells. The spread of breast cancer isn't random at all. It's remarkably sequential. As a primary breast tumor grows, it sheds cancer cells into the cellular spaces, and they get swept right up into that lymphatic transit system we just mapped. Because the flow is entirely directional, these metastatic cells invade the axilla in a strict, predictable order. They hit level 1 first, then progress to level 2, and eventually make their way to the apical nodes at level 3. This cause and effect model is exactly why understanding the anatomy is absolutely crucial. Honestly, the extent of this sequential spread is traditionally the single most important predictor for a patient's overall survival.
And this internal microscopic spread, it actually has very visible real-world consequences. You might have heard the clinical term peau d'orange, which literally translates to orange peel. When cancer cells completely permeate and block the dermal lymph vessels, the normal fluid drainage from the skin just stops. This internal blockage causes localized edema or swelling, but the skin itself remains tightly tethered down by the suspensory ligaments of Cooper. Those are the fibrous bands that give the breast its shape. So the swelling pushes up, the ligaments pull down, and the result is this dimpled, pitted appearance on the skin that looks exactly like an orange peel.
As the disease progresses, the lymph nodes themselves literally physically transform. You know, a normal healthy lymph node is soft and kind of hard to define, but when it fills with metastatic cancer, it becomes distinctly firm, even hard. As the cancer grows, these once separate nodes start sticking together, forming a solid conglomerate mass. Eventually, if left unchecked, the cancer cells can break right through the lymph node's outer capsule and fuse tightly to surrounding structures, including the chest wall itself. Being able to feel these physical changes during an exam gives doctors immediate, critical clues about the stage of the disease.
Okay, so we've mapped the healthy anatomy, and we've tracked the dangerous pathology. The big question now is, how do modern surgeons actually use this exact anatomical map to stop the spread in its tracks?
Let's move into our final phase, Part 4, Staging and Surgical Interventions.
The surgical approach to the axilla has evolved so dramatically over the years. Back in the 1940s, the standard treatment was incredibly aggressive, radical mastectomies that removed the breast, the lymph nodes, and all the major chest muscles. It was brutal. But then in 1948, Patey and Dyson at the Middlesex Hospital made a massive breakthrough with the modified radical mastectomy. They proved that by just removing that smaller pectoralis minor muscle we talked about earlier, surgeons could fully access and clear out axillary levels I, II, and III, all while saving the large pectoralis major muscle. Fast forward to today, and we've evolved even further to highly targeted, incredibly minimally invasive techniques.
Today, this mapping builds into a truly elegant, precise procedure called sentinel lymph node mapping. The whole idea relies on finding the very first, or sentinel node, that receives drainage from the tumor. Surgeons do this by injecting a radioisotope or dye paratumorally, meaning right around the tumor itself, or into the subareolar plexus. They can then literally trace the lymphatic flow in real time as it moves toward the axilla. Once they find it, the surgeon carefully excises just that very first sentinel node to check it for cancer cells under a microscope.
Now, the clinical importance of this procedure, it's an absolute game changer. By proving that the sentinel node is clear of cancer, surgeons can confidently determine that the rest of the axillary nodes down the line are also clear. That means sentinel node dissection safely spares up to 75% of clinically node-negative patients from having to undergo a full invasive axillary dissection. This beautifully precise use of the anatomical map saves patients from intense surgical side effects like severe arm swelling and permanent nerve damage that almost always accompany the complete removal of those axillary nodes.
Which leaves us with a pretty fascinating thought about the future. We've seen how our understanding of the breast's lymphatic architecture has moved surgery from highly invasive muscle removal all the way down to delicate single-node extractions. With the rapid advancement of supersensitive imaging tools like ultrasound and PET-CT scans, you have to wonder, could we one day map these microscopic highways and detect cellular hitchhikers entirely without the need for any surgical staging at all? It's a provocative thought for sure, and it just shows how vital this anatomical map remains in our ongoing fight against breast cancer. Thank you so much for joining me on this explainer.